So the DSM-5 working group came up with a number of changes, and we land on our now current model of this bimodal model of autism. So you're moving away from this triad or this three-domain model to a two-domain model. And you get these criteria elaborated. Now, the things to pay attention to on this slide really are that the criteria, as I said, are bimodal. Social and communication are in one area, and restricted interest and repetitive behaviors in the other. Actually, I'm going to move forward and come back to this in a second. Yeah, actually, I'm going to start and go here and come back to that. So the term, let's just talk about the major changes. So one of the major changes was obviously changing the term from PDD, pervasive developmental disorder, which no one really liked. It was cumbersome. It didn't really accurately describe it. It got overlapped with other developmental disabilities. People didn't know what it meant. And so we needed to get rid of it. So ASD gets used as the overall label for the group of disorders. As well, the idea that the subtyping phenomenon or practice that we had gotten used to or gotten involved with trying to subtype types of autism was really not scientifically supported, and we needed to really look at it as a broader spectrum. And perhaps that what they were starting to see was that the idea of subtypes perhaps were not so much different types of autism as perhaps reflecting more the comorbidity burden. We're going to be talking a lot about comorbidity as the day goes on. The other is obviously the shift to this two-domain model. And this two-domain model is really a collapsing of the social domain and the communication and imagination domain into one area. Why is that happening? Well, why that happened was in large part because of clinical assessments. Is that in clinical assessment, it is really almost impossible to separate out the social impairments when your child also has communication impairments, particularly when they're at school age or above. That the two are so intertwined that you really can't effectively separate the two. So if you can, all you end up doing is double counting or overemphasizing, which was part of that whole swing of pendulum. So the idea was if we kind of streamline and merge these, that perhaps we're going to have a much clearer way of identifying things that's going to be reliable. Yes. And the third major thing you want to take away from the DSM-5 is this increased emphasis on the restricted interests, repetitive behaviors, RIRB, RRB, however you want to talk about it. Now, why did they emphasize that? Well, the reason they emphasized that was because of issues that related to stability of diagnosis and specificity of diagnosis, meaning getting the kids who actually had it and ruling out the ones who didn't have it. And what the research had established by that point was that the vast majority of kids with autism spectrum disorders demonstrate at least some of the quote-unquote prototypical, the classical autistic repetitive interest and restricted interest or repetitive behaviors, at least by adolescence. So it's if you can identify it, it's likely to increase your specificity. As well, we understand that the stability of the diagnosis, if you identify it early, is much greater. Meaning that if, in absence of a restricted interest in repetitive behavior, the stability of a diagnosis made at age 3 is not so great. But if you see evidence of those behaviors at age 3, then it's much more likely at age 8 or 9 that this same child is going to still be identified with autism. And so now we'll go back to this slide here. So what you see is the two-domain model. The other thing to pay attention to is the number of criteria that are required. So in DSM-5, you actually require all 3 of the social communication deficits in some form, either in history or in observation. Social, emotional reciprocity, nonverbal communicative behaviors like eye contact and gesture, and social relationships. The second part are the restricted interest and repetitive behaviors. Now, you remember I said a few minutes ago that in DSM-4 and 4TR, you could actually make a diagnosis of ASD or PDD without having any restricted interest and repetitive behaviors. The ante gets upped substantially in DSM-5. Not only do you have to have any, you have to have at least 2 of these 4 criteria being met. Now, they changed the criteria a little bit, so in order to incorporate some of the developmental concerns, and we could talk about that if that comes up. But the overall idea here is that clearly you need to have these restricted interest and repetitive behaviors in order for us to call this autism. The other kind of sub-criteria, I apologize, this is a little bit small, is that the symptoms must be present in the early developmental period. Now, what is the early developmental period? Generally, we think about it before the age of 3 or 4 years of age. Why is that the case? Because if you don't have evidence of these symptoms prior to the 3 or 4 or 5 years of age, what you might be seeing cross-sectionally is not autism, but something different. Autism does not emerge late. Now, that does not mean that you can't have autism that gets identified late. And it has to do with a whole number of issues in terms of context, availability of services, or symptom intensity. Higher functioning, intelligent kids who are well scaffolded, who don't have a lot of other psychiatric comorbidity may not actually get picked up until quite a bit later. But when you actually go in and you look at the history, you find out, well, yes, no, there were issues going back to the early developmental period. So there has to be roots of this condition in the early developmental period. The D criteria obviously has to be clinically significant, so you're not case finding, you're not going around schools and saying, you're a geek, I'm going to call you autism. You don't have any problems, but we're going to call it because you look like the guys on some of those, what's that TV show? That one. All right. It really annoys me, that show. The other thing that they talk about is this concept of intellectual disability, which doesn't really kind of get elaborated very much in the previous documents. And what it really tries to do is sort out how does intellectual disability and autism relate and configure with each other. The fact of the matter is we know that a number of individuals with autism spectrum disorders also have intellectual disability. The proportion has varied, or estimates have varied over time. Now we probably say maybe a little less than half of individuals have some degree of intellectual disability, although even that is shifting. But when you see kids who are really intellectually disabled or delayed or impaired, kids who are functioning at below, say, 18 or 24-month age equivalent, what you end up seeing is everything is so low, including social and communication and interests and behaviors and imagination, that it becomes very hard to differentiate autism from intellectual disability. So they specify that, yes, you can make a diagnosis of autism spectrum disorder in the context of intellectual disability, but you have to have these specific hits. You have to have these specific areas where even beyond the intellectual disability, you are seeing impairments in social behaviors, impairments in communication, or evidence of the repetitive interests or behaviors. So, nope, we did that, we did that, we did that. And yes, that's what I thought we were going to be. So we end up with this two-domain model, and I think, again, the take-home messages are, yes, autism is still at core a social communication disorder. However, it has to be complemented by these repetitive interest or restricted behaviors. That is a syndrome today that we are talking about.